Dear friends, today we are going to see thyroid ultrasound. Our topic of discussion is thyroid ultrasound. As you know, thyroid is a ductless endocrine gland present in anterior neck which is responsible for growth, development, metabolism in the body. It also influences temperature regulation. Now coming to ultrasound. Who should go for thyroid ultrasound? If your clinician feels that there is any mass, lump or a swelling around your neck region, then you should go for thyroid ultrasound. If abnormal TSH levels are seen in case of a person, then he or she should go for thyroid ultrasound. If there is a family history of thyroid malignancy, these patients also should go for thyroid ultrasound. To check radiation hazards, also you can go for thyroid ultrasound. Or as a part of routine checkup also you can go for thyroid ultrasound. Now location. This gland is located in anterior neck spanning from C5 to T1 vertebrae. Anteriorly it is related with sternocleidomastoid muscles, strap muscles. Strap muscles involve sternothyroid, sternohyoid. Posteriorly it is related with trachea, esophagus, longus colli muscle. On either lateral side it is related with common carotid arteries, internal jugular veins. So these are the relations of thyroid gland. Now structure. This gland is H-shaped in structure. It has got right lobe, left lobe, isthmus. Right lobe can be measured, left lobe can be measured. Volume of this gland can be calculated by calculating volume of right lobe and left lobe. Isthmus volume is not considered while calculating volume of this gland. How to measure these lobes and calculate the volume of gland, we will see that in our practical session. Now blood supply. Blood supply of this gland is by superior and inferior thyroid arteries. This is a highly vascular gland. It's venous drainage. Venous drainage of this gland is by superior, middle and inferior thyroid veins. Superior, middle and inferior thyroid veins, they form a plexus around this gland, and this plexus can be well seen on Doppler and on ultrasound, that we will see in our practical session. Now superior and middle thyroid vein opens into internal jugular vein, whereas inferior thyroid vein opens into brachiocephalic vein. Now lymphatic drainage. Lymphatic drainage of this gland is multidirectional. It is in perithyroid region, pretracheal region, paratracheal region, mediastinal group of lymph nodes. These lymph nodes can be seen on Doppler and on ultrasound, that how these lymph nodes appear and where to see for these lymph nodes, that we will cover it in our practical session. Now, for what reason you need to evaluate thyroid gland? The conditions can be briefly classified into acquired conditions and congenital conditions. Congenital conditions involve congenitally absent thyroid gland. A empty thyroid fossa can be seen in few patients. A hypoplastic thyroid gland may be seen in cases of few people. A ectopic thyroid gland may be seen anywhere in the neck region, or extra lobe may be present arising from isthmus, that is a pyramidal lobe. Ectopic thyroid gland that I have already mentioned, it can be present anywhere in the neck region. So these are the congenital conditions. Now acquired conditions. Acquired conditions involve benign conditions, malignant conditions. Benign conditions involve benign adenomas. Adenoma can be a solitary nodule or a multinodular goiter. When you see a nodule in case of a thyroid gland, you will try to evaluate it whether this nodule is benign or malignant by your radiological diagnosis. See, most of the times you will be able to detect which nodule is benign and which nodule is malignant, but not always. For that purpose, you need confirmatory tests like fine needle aspiration biopsy, elastography, and PET scan. These will be the confirmatory tests. Depending on the appearance of thyroid gland and nodules, you can classify these nodules into three groups: completely benign appearing nodules, borderline, and malignant appearing nodule. A completely benign appearing nodule doesn't need further evaluation. You can skip further investigations for completely benign appearing nodule. But if the nodule is borderline or malignant appearing, needs further investigation. Now, how to evaluate these nodules? By their appearance on ultrasound and on Doppler. See, 95% nodules in case of a thyroid gland are benign. Only 5% nodules in case of a thyroid gland are malignant. Now, when you see a nodule in case of a thyroid gland, you should follow this criteria to differentiate whether it is a benign appearing or a malignant appearing or borderline. You should see its shape first of a nodule. If it is oval in shape, it is more likely to be a benign nodule. If it is rounded in shape, it is more likely to be a malignant nodule. If presence of sinus is seen in case of a nodule, then it is more likely to be a benign nodule. If absent sinus is seen in case of a nodule, then it is more likely to be a malignant nodule. If presence of eggshell calcification is seen around nodule, then it is more likely to be a benign nodule. If coarse eggshell calcification is seen around nodule, then it is more likely to be a malignant nodule. If a halo sign is seen around nodule, then it is more likely to be a benign nodule. If absent halo sign is seen on Doppler and on ultrasound, then it is more likely to be a malignant nodule. If microcalcification is seen in case of a nodule, then it is more likely to be a malignant nodule. Microcalcifications, these are the Samoma bodies, we will come across it. These are seen in case of malignant nodules. If absent microcalcification is seen, it is in favor of a benign nodule. A nodule which is highly vascular on ultrasound and on Doppler is usually a malignant nodule. A nodule which is less vascular or avascular on Doppler is less likely to be a malignant nodule. Earlier days, vascularity pattern used to suggest you that which nodule is benign and which nodule is malignant, but with newer machines and advanced technology, this is non-specific. When a nodule appears cystic completely, then you can label it as a cyst. Like as usual, cyst can be of two types: simple cyst and a complex cyst. Simple cyst will have complete cystic appearance and it is usually a benign cyst. But a complex cyst will have solid and cystic both components. It may have septations. Complex cyst can be a malignant, can be a benign, both. So while taking fine needle aspiration biopsy of complex nodule, you should take its solid component also. If the cyst has got internal echoes inside the cyst, again there are three types of cyst which show internal echoes in the cyst. Depending on the internal echoes, which material it is, it can be labeled as colloid thyroid cyst, hemorrhagic thyroid cyst and infective thyroid cyst. But all these three will appear similar on Doppler and on ultrasound. Your job as a radiologist is only whether internal echoes are present or absent. That's what is expected. A falling star appearance may be seen in case of colloid thyroid cyst. Colloid thyroid cyst, which is otherwise known as iodine deficiency goiter. See, when you see a nodule in case of a thyroid gland, I would like to suggest you one clinical examination. It's not a part of our radiological diagnosis, but it will be of a great help to you while diagnosing which nodule is benign and which nodule is malignant. When you see a nodule in thyroid region, you palpate it. If it is soft in consistency and easily movable, then we can label it as a benign nodule in your mind. If the nodule is hard in consistency and attached to some of the part of thyroid gland or a body part, then it can be a malignant, it can also be a benign. But easily movable, soft in consistency, these characteristic features are of a benign nodule usually. Of course, fine needle aspiration biopsy, elastography and PET scan will be the confirmatory test. Another cyst is lingual cyst. Lingual cyst is a remnant of thyroglossal duct that is usually attached to the base of tongue. So this is another cyst. Now we will see malignancies of thyroid gland. There are several varieties of thyroid malignancies, but these 5 are most common: papillary cell carcinoma, anaplastic carcinoma, medullary carcinoma, follicular carcinoma, and Hurdle cell carcinoma, out of which papillary cell carcinoma is the most common variety of thyroid malignancy, and anaplastic carcinoma is a highly aggressive tumor of thyroid gland, and usually it is diagnosed in late stages because of its nature to grow very fast. A papillary cell carcinoma usually shows a microcalcification. This microcalcification is usually a psammoma bodies which can be seen on Doppler and on ultrasound. All these 4-5 varieties of thyroid malignancy, they appear more or less similar in appearance on Doppler and ultrasound. So you won't be able to always differentiate between which type of malignancy it is, but you will be able to detect whether malignancy is there or not. Confirmatory test already I have told you: biopsy, fine needle aspiration biopsy, PET scan, and elastography. Now, inflammation of thyroid gland is known as thyroiditis. Thyroiditis can be because of many reasons. This thyroiditis can be grouped into 3 groups. There are several varieties of thyroiditis, but briefly they can be classified in 3 groups: acute thyroiditis, subacute thyroiditis, and chronic thyroiditis. Acute thyroiditis is a painful condition, and usually it is caused by infection, viral infection or bacterial infection. Subacute thyroiditis involves granulomatous thyroiditis, lymphocytic thyroiditis, lymphocytic thyroiditis can show you a pseudonodular pattern. Chronic thyroiditis involves chronic lymphocytic thyroiditis, which is otherwise known as Hashimoto's thyroiditis. And Graves' disease is another variety of chronic disorder of thyroid gland. When you see a thyroiditis in case of a person, that means when you try to evaluate whether thyroiditis is there or not, you won't be able to diagnose or differentiate between types of thyroiditis by doing color Doppler and ultrasound. But most of the time, at least maximum time, you will be able to detect whether thyroiditis is present or absent, because all these thyroiditis they appear more or less similar on Doppler and on ultrasound. A heterogeneous hypoechoic pseudonodular appearance of thyroid gland is suggestive of thyroiditis. Increased vascularity, that is thyroid inferno, that is another variety which can be seen in case of thyroiditis on Doppler. There are few thyroiditis which are caused by pregnancy induced thyroiditis, postpartum thyroiditis. So, these are the conditions which are reversible. When you see a thyroid gland which is enlarged in size, just by seeing enlarged thyroid gland, you should not label it as a thyroiditis. You should always clinically correlate with TSH levels. If TSH levels are normal and gland appears to be enlarged in size, it can be a variation. Few patients may have larger gland, but if the TSH levels are normal, then you should label it a normal only. Females, they have bigger thyroid gland that as compared with males. So, always clinically correlate with TSH levels. If TSH levels are normal and gland appears enlarged in size, then you should label it as normal.